Greetings to my fellow Americans and to all Medicarians. To you, to members of the 118th Congress, to CMS, the Center for Medicare and Medicaid Services, to the Supreme Court, and distinguished guests. This evening, I am pleased to give you my 2024 Medicare State of the Union Address. This will be a good news and a bad news address. And in this address, I'm going to discuss the economics of Medicare, the need to eliminate the Part A skilled nursing 3-day rule, Medicare marketing issues and scams, Medicare Advantage, Medicare Supplements, and propose a One Price for All Act. Since 1965, the federal government has offered national health care to people 65 and over and to people with certain long-term disabilities. Medicare plays a major and ever-increasing role in the U.S. healthcare system. I remember in 2014 when I walked into someone's home almost every time before I could even sit down, I was asked the question, what do you think of Obamacare? And I said, well, we've had national health care since 1965 and you are on it. How's it working for you? And they usually say, good. Original Medicare covers the vast majority of medical and health procedures and covers most of the costs for those procedures. But Medicare beneficiaries can still incur significant costs in their medical care. These gaps in coverage can be covered by either a Medicare supplement policy, Medicaid from the state, sometimes Medicare Advantage, or through a group, government, or military retiree insurance policy. But Medicare has a dilemma. There are over 65 million Medicarians, and by 2060, there will be an estimated 93 million Medicarians. Right now, every day, another 12,000 baby boomers are turning 65, and most are going on full Medicare. They are living longer than previous generations. There are amazing advancements in medical technology, and healthcare inflation is outpacing regular inflation. From 2000 to 2022, Medicare spending per person has grown, increasing from $5,800 to $15,700. Right now, Medicare accounts for about 12% of the federal budget. Going into the future, net Medicare expenditures are projected to increase from $744 billion in 2022 to nearly $1.7 trillion in 2033 due to growth in the Medicare population, increases in healthcare costs, new technologies, and the increasing volume and use of services. As baby boomers get older, they are going to want more advanced and alternative healthcare options. So as people live longer, they are more likely to develop medical problems. The National Center for Health Statistics estimates that about 24% of people 65 and older have at least one chronic condition, and about 27% have two or more chronic conditions. As over 4 million baby boomers are going on to Medicare each year and nearly 70% of them are retiring, that means the federal government is no longer collecting the 2.9% payroll tax on them. So the question that is on the mind of many Medicarians as well as Congress is, will Medicare run out of money? Or how are the Medicare trust funds holding up? There are two different trust funds for Medicare. The Hospital Insurance Trust Fund, which is funded by the 2.9% payroll tax and that covers Medicare Part A expenses. And the second is the Supplementary Medical Insurance Trust Fund, which is funded by Part B premiums and general revenues. In regard to the Hospital Insurance Trust Fund, your Part A, the most recent Medicare trustee report states, quote, total Medicare expenditures were $905 billion in 2022. And the board projects that they will increase in most future years at a somewhat faster pace than the aggregate workers' earnings or the economy overall. As it has since 2004, the Hospital Insurance Trust Fund fails to meet the Board of Trustees' short-range test for financial adequacy. In addition, as in all past reports, the Hospital Insurance Trust Fund fails to meet the trustees' long-range test of close actuarial balance. Surpluses are expected to continue through 2024 and then turn to deficits for the remainder of the 75-year projection period. The projected trust fund depletion date is 2031, 3 years later than estimated in last year's report. It goes on. Policymakers should determine effective solutions to the long-range hospital insurance financial imbalance, even assuming that the provider payment rates will be adequate. The hospital insurance program does not meet either trustees' short-range test of financial adequacy or long-range test of close actuarial balance, unquote. Thankfully, quote, to date, lawmakers have never allowed the assets of the Medicare Hospital Insurance Trust Fund to become depleted, unquote. In regard to the Supplemental Medical Insurance Trust Fund, your Part B and Part D, The report states, quote, "The trustees project that both the Part B and Part D accounts of the Supplementary Medical Insurance Trust Fund will remain in financial balance for all future years because beneficiary premiums and the general fund transfers are assumed to be set at a level to meet expected costs each year. However, supplementary medical insurance costs are projected to increase significantly as a share of GDP over the next 75 years from 2.2% to 4.2% under current law." It goes on. Quote, "Policymakers should also consider the likelihood that price adjustments in current law may prove difficult to adhere to fully and may require even more changes to address the financial imbalance," unquote. The Medicare Trustees report also states, quote, "Medicare's actual future costs are highly uncertain for reasons apart from the inherent challenges of projecting healthcare cost growth over time. The financial projections in this report indicate a need for substantial changes to address Medicare's financial challenges. The sooner solutions are enacted, the more flexible and gradual they can be. The projections in this year's report continue to demonstrate the need for timely and effective action to address Medicare's remaining financial challenges, including the projected depletion of the Hospital Insurance Trust Fund, this fund's long-range financial imbalance, and the rapid growth in Medicare expenditures. Furthermore, if the growth in Medicare costs is comparable to growth under the illustrative alternative projections, then policy reforms will have to address much larger financial challenges than those assumed under current laws. So what solutions might we have? 1, encourage and challenge all Americans and Medicarians to live a more healthy lifestyle. Now, I know I may be meddling, but many American seniors choose to live an unhealthy lifestyle by having a poor mindset, eating too much, drinking too much, and smoking too much, and they rely on a drug to make them feel better. Instead, if more people took an active role in their health by having the proper mindset, eating healthier, and exercising, then they'd feel better, enjoy life more, suffer less chronic conditions and health issues, spend less on their health care and less time in the doctor's office. And I encourage and challenge healthcare professionals to get in shape themselves and to prescribe to their patients a proper diet and exercise program instead of a drug all the time. Find a reasonable way to reduce the cost of prescription medications while at the same time pharmaceutical companies will still be motivated to develop good and necessary medications. Right now, the big pharmaceutical companies are on the top of the healthcare pyramid, with you and me being at the bottom. The United States spends over twice as much on prescription drugs as other developed nations. U.S. prices were 256% higher than those in 32 comparison countries combined. In comparisons with individual countries, U.S. prices range from 170% of prices in Mexico to 779% of prices in Turkey. Now let's talk about Medicare Part A skilled nursing coverage. Your Medicare Part A covers up to 100 days of skilled nursing care, and Medicare pays the full cost of the first 20 days, and then from day 21 to 100, you pay $204. But there is a very glaring problem with Part A skilled nursing coverage that causes hardship to many Medicare beneficiaries, and that problem is the 3-day covered stay rule. For a Medicare beneficiary to be covered for skilled nursing care, they must first have a 3-day covered inpatient hospital stay. Now, while many people that enter skilled nursing have needed to be inpatient in the hospital for at least several days, it is not always the case. What happens when someone doesn't need to be in the hospital and really needs to be in skilled care? Well, under original Medicare and even with a Medicare supplement, you simply won't be covered and will be responsible for the full cost of your skilled nursing stay if you haven't had the 3-day inpatient hospital stay. You could try to be admitted to the hospital, but they may not admit you in the first place if you don't need to be there. Or if they do, they may discharge you before your 3-day inpatient stay is up, ironically because you may not be meeting the Medicare requirements for an inpatient stay. Or possibly because the hospital needs to make room for someone else. Whereas with a Medicare Advantage plan, you don't need the 3-day hospital stay and can be admitted into a skilled nursing facility directly from your home, your doctor's office, or less than 3 days in the hospital. So I appeal to Congress and CMS to eliminate the required 3-day inpatient stay. When Medicare started in 1965, according to the NIH report waiving the 3-day rule from 2015, quote, The average hospital length of stay was 2 weeks, and 3 days represented the minimum time necessary for appropriate evaluation and post-discharge planning. Medicare does not require a qualifying 3-day stay for other forms of post-acute care, including home health visits or a stay in an inpatient rehabilitation facility. They go on to say, quote, nearly 1 in 5 Medicare-financed acute hospitalizations concludes with a discharge to a skilled nursing facility. These trends raise the possibility that the 3-day stay policy may both inappropriately lengthen acute hospital stays for patients who could be transferred to a skilled nursing facility earlier, as a result, increase spending on avoidable hospital care and increase patients' exposure to other complications, unquote. CMS's Innovation Hub did a study where the 3-day hospital stay requirement was waived. They determined use of the waiver did not increase Medicare costs. Beneficiaries had lower or similar adverse outcome rates when compared to those not under waiver. Beneficiaries under the waiver had shorter skilled nursing facility length of stays, but skilled nursing facility discharges to home health or to the home also increase. So, write your congressmen and senators and ask them to eliminate the 3-day inpatient hospital stay for skilled nursing coverage. Now here's a big one: Medicare marketing issues and scams. Every day, seniors and other Medicare beneficiaries are duped into Medicare marketing propaganda and scams. No doubt you've seen the countless ads promoting Medicare plans where you can get all you deserve, get what you're entitled to, get money back on your Social Security check, get dental, vision, and hearing covered, and of course, get your grocery card. And every day, seniors and Medicarians are bombarded with unsolicited telephone calls that violate Medicare marketing rules. As a licensed insurance agent, I am not allowed to make the initial contact with a Medicare beneficiary, meaning I can't cold call you. But these big, corrupt, and unrighteous telesales insurance brokerages do just that. Then they routinely mislead people into changing their Medicare coverage and typically into a Medicare Advantage plan. They don't tell people that your Medicare supplement won't work with your Medicare Advantage, your provider can leave the network at any time, your medications may cost you more, and your out-of-pocket costs could be much higher. Instead, all they allure you with is all the extras. Folks, extras are not why you choose a Medicare Advantage plan or any plan at all. So I appeal to you as an American and Medicarian that you simply don't answer phone calls from people you don't know, and that you don't call those 800 numbers that you see on TV. You can see my videos. My client lost $3,276 because she called an 800 number Medicare ad. Oh no, just got a Medicare Advantage plan, 7 things you weren't told, and warning, don't be fooled by 800 number Medicare ads. Next, I appeal to Congress and CMS to eliminate the pre-annual election period from October 1st to October 14th. It is unnecessary. It wastes time, causes confusion to Medicare beneficiaries, and compromises their enrollment if they send in a paper application too early. Instead, the logical thing to do is start the annual election period on October 1st and have it end on November 30th. This is much simpler and benefits both the Medicare beneficiary and the insurance companies. I also propose to eliminate the ridiculous and childish Medicare scope of appointment form requirement. The SOA form is a form that all Medicare beneficiaries must physically sign, electronically sign, or verbally agree to before an agent can speak with them about anything related to Medicare Part C Advantage plans and Medicare Part D drug plans. And unless the Medicare beneficiary called in or walked in unannounced, then a Medicare beneficiary has to wait 48 hours before an agent can review plan benefits with them, even if that person is already an existing client. It is ridiculous and it is unprofessional. Meanwhile, an agent can cold call you and even come knock on your door if they are going to talk about Medicare supplements, and you can bank on the fact that some Medicare supplement companies send their agents door to door to market people turning 65. While the form is meant to protect Medicare beneficiaries from being solicited about something they aren't interested in, it does very little to help with that, and it has proven that over time. As an agent, I don't need your signature on a silly form to speak to you professionally and freely about Medicare supplements, long-term care, annuities, life insurance, or any other health-related product. Requiring agents to have Medicare beneficiaries sign the scope of appointment is cumbersome, time-consuming when a person has to wait 48 hours, and it's truly unprofessional. CMS calls the 48 hours a cooling off period. Give me a break. Cooling off from what? I couldn't even tell a Medicare beneficiary anything about Part C or Part D plans to get them all excited and hot over. What is there to cool off? Nothing, folks. It is not the small independent agent or brokerage that is causing the majority of complaints to CMS. It is the big telemarketers and 800 number ads. But ironically, if you call an 800 number ad about a Medicare Advantage plan or Part D drug plan, they don't even need to have you sign the form, let alone wait 48 hours. So to Congress and CMS, get rid of the scope of appointment now. On to Medicare Advantage. Medicare Advantage plans are also known as Medicare Part C, and they now cover over 50% of all Medicare beneficiaries, and that percentage is only going to increase. By all accounts, and with numerous studies and reports, the vast majority of Medicarians that have Medicare Advantage plans are satisfied with their plans. Some reports have shown that people on Medicare Advantage have better healthcare outcomes and less readmittance to the hospital as compared to those on original Medicare. Medicare Advantage is required to cover all procedures and treatments that original Medicare would. Medicare Advantage combines your Medicare Part A, Part B, and usually your Medicare Part D drug coverage, and then the plans typically cover additional benefits like routine dental, routine vision, and routine hearing. Unfortunately, the big insurance brokerages and telesales agencies only focus and push the extra benefits. Folks, you don't choose a Medicare Advantage plan because of the extra benefits and a grocery card. You pick a Medicare Advantage plan based on the prescription coverage, the provider network, and the flexibility to go out of network, your financial risk exposure. So who cares if you get a $50 grocery card benefit each month, but you are on the hook for $8,000 in potential co-payments when you could only be on the hook for $3,000 in potential co-payments. Consequently, every year, tens of thousands of Medicare beneficiaries are duped and misled into enrolling into a Medicare Advantage plan that they don't understand how it works, they don't know the true pros and cons, and you can see my videos. Oh no, just got a Medicare Advantage plan, 7 things you weren't told, the 3 main risks with Medicare Advantage, the 3 main rewards with Medicare Advantage. Is Medicare Advantage a scam? In addition, they are not told they have inferior prescription coverage, their doctors are not in the network, and they are not told that their doctor can leave the network at any time. They've lost access to a specialty hospital. They will have to deal with more prior authorizations for treatment and benefit denials as compared to original Medicare. And they aren't told that their Medicare supplement doesn't work with Medicare Advantage. Consequently, right now, there are tens of thousands of Medicare beneficiaries that are still paying on their Medicare supplement, and it doesn't help them at all. So I appeal to Congress and CMS to make a rule that requires all agents, telemarketers, insurance companies to ask if someone has a Medicare supplement, and if they do, notify them that their Medicare supplement doesn't work with Medicare Advantage, and they should cancel the policy. And for the new Medicare Advantage company to send a letter to the new member about Medicare supplements and how they don't work with Medicare Advantage. And again, you can see my video about how one of my clients lost $3,276 because she called an 800 number Medicare ad and didn't know to drop her supplement. And what about the prior authorization issues with Medicare Advantage? Because Medicare Advantage is more managed care, insurance companies are more likely to either require prior authorization for a treatment or deny the claim outright when original Medicare would not have. Now, there are times when prior authorizations are in fact helpful and do protect the Medicare beneficiary from unnecessary procedures and costs. Thankfully, Congress and CMS are addressing this issue, but more needs to be done. I propose to Congress and CMS several options. If original Medicare doesn't require a prior authorization, then neither should Medicare Advantage. If a prior authorization is required by the Medicare Advantage company, and that treatment were to be denied by the Medicare Advantage company, then if the Medicare Advantage member can get a validating second opinion, then the procedure or treatment must be covered by the Medicare Advantage company regardless. They could reduce the extra benefits that many people don't utilize and in many cases don't even know they have, and use those savings to help cover treatments and procedures that may have otherwise required a prior authorization or been denied outright. If you look at this chart, you'll see the average Medicare Advantage plan for 2024 offers a combined $8,261 for routine dental, vision, and hearing, and most of that isn't utilized. I also propose to Congress, CMS, and the Medicare Advantage companies the following. Reduce the number of plans one company can offer in a region or state. There are simply way too many plans for people to pick from. It makes it more confusing and entices the bad agents to solicit Medicare beneficiaries to change their plan when they don't need to. Also, I would suggest that the Medicare Advantage companies offer a nationwide Medicare Advantage plan, one plan available anywhere in the United States. Simple. Each Medicare Advantage plan should allow the prospective enrollee to choose their additional coverage. Example, instead of having varying amounts of extra benefits for things like routine dental, routine vision, routine hearing, over-the-counter items, Part B premium reduction, and of course the grocery cards in place, just give a simple dollar amount benefit, say $4,000, that can be used at the member's discretion for healthcare related treatment. You see, many people don't need $2,000 worth of dental coverage when they wear dentures, and most don't need $3,000 for hearing aids when their hearing is perfectly fine. And thus, these benefits are not used or maximized by many people. This simple dollar amount benefit could either be used to reduce the maximum out of pocket, or would be assessed through a debit card and could be used for routine dental, vision and hearing, over-the-counter medications, vitamins and supplements, medical equipment, alternative treatments for like chiropractors, acupuncture, and cancer. Maybe Medicare doesn't cover an alternative treatment. Well, these funds can be used at the member's discretion to pay for that alternative treatment. You could use it for exercise or fitness classes, healthy food and groceries, and even regular provider co-payments. This would be much better for people. This would make the extra benefits much more efficient to utilize for the member as well as the insurance companies. Think about it. The member would not have to pay up front and then submit a claim to the insurance company, and the insurance company would not have to deal with claims for these benefits because the payment is going directly to the provider or supplier. Okay, what about Medicare Supplements? Medicare Supplements, also known as Medigap plans, have been around since 1966, and prior to Medicare Advantage were the main option for additional health care coverage. Depending on your age, there are 9 to 12 different Medicare Supplement options, and some of those options, quite frankly, are confusing, unpredictable, and have some serious gaps in coverage, especially the plans K and L. Fortunately, most Medicarians pick either the Plan G, the Plan N, and a small percentage do choose a high deductible G. Since almost 100% of Medicare beneficiaries pick from primarily just 2 of the 9 to 12 options, I'm proposing to Congress and CMS that the current Medicare supplement options be phased out and be replaced with a tiered deductible option with a minimum deductible of $500 per year and a maximum deductible of $2,500 per year. This deductible would apply to any Part A and Part B service. They would never increase due to the Consumer Price Index like the high deductible G currently does. This would allow Medicare beneficiaries to have more freedom and flexibility in choosing their coverage based upon their unique healthcare needs, finances, and philosophies. The tiered deductible option is also easier for most people to understand. It's simple. Once you've met the deductible, then your Medicare supplement pays 100% of what Medicare doesn't pay. Let's talk about healthcare charges. Right now, medical billing and coding is confusing, and in my view, it is unfair, unethical, and unrighteous. Providers charge one amount for a certain service, procedure, or medical code, but what they actually receive varies on who the final payer is. Medicare has their reimbursement rate, Medicaid has their reimbursement rate. Insurance companies all have their own individual reimbursement rates, and the person that is self-pay, as in paying out of their own pocket, many times has to negotiate with providers to receive a discount, and the discounts they may receive oftentimes are nowhere near as much as Medicare, Medicaid, and an insurance company would receive. I certainly expect that every provider make a fair profit on their services, but the price they charge and what they are actually willing to receive should be the same regardless of who the final payer is. So I appeal to Congress, hospital groups, provider groups, and pharmacies that their charges for services are the exact same regardless of who the payer is. It shouldn't matter if the final payer is Medicare, Medicaid, insurance company, or an individual who is self-pay. An individual should be able to receive the same discounted rates as Medicare and an insurance company receives. In addition, if a patient visits a provider, and especially if it's in the emergency room, the patient should not end up receiving multiple bills from multiple entities because they made one visit to the ER. Congress worked to pass the No Surprises Act. I'm now asking Congress and the healthcare world to come up with the One Price for All Act. In conclusion, Medicare and even Medicare Advantage continues to work well for the majority of Medicare beneficiaries. But as noted, there are some definite pitfalls. These pitfalls should be relatively easy to overcome if Congress, CMS, the insurance companies, providers, and Medicare beneficiaries work together to provide a better overall healthcare experience for millions of seniors and those with certain long-term disabilities. Thanks for watching and listening. I greatly appreciate your feedback on this, and let me know how you would like to see Medicare improve. I'm Chris Prang, the Medicare analyst. Make it a great day, and may God bless America.